Good afternoon, everybody. Welcome to the CWORPH webinar series. Today's presentation, we will be talking about two projects in the CWORPH funded projects around implementation of an evidence-based public health workforce loan repayment program as a recruitment incentive and distinguishing characteristics of public health occupations compared with existing Standard Occupational Classification codes, SOC codes. So I am Beth Resnick. I am a practice professor from the Johns Hopkins Bloomberg School of Public Health, and I will be your moderator for today's session. And as I said, these are projects from CWORPH, Consortium for Workforce Research in Public Health. We are a workforce public health research center that is funded by HRSA and CDC. We are a collaboration of universities housed at the University of Minnesota, but with researchers from Columbia University, East Tennessee State, Indiana University, Johns Hopkins University, and the University of Washington. So first, I'm going to just share a little bit about our webinar, and then we'll get into our content. So again, as I said, CWORPH is HRSA and CDC funded. We're the only health workforce research center that focuses specifically on the public health workforce, and we appreciate you all being here today to hear about our year 2 projects. Just another quick item about CWORPH. We are funded by the CDC National Partners Cooperative Agreement to help support recruitment and retention in local public health departments. And we also have just completed a recent national enumeration of the public health workforce, and you can find more information on that on the CWORPH website, which we can put in the chat for you. So specifically for today, for guidelines for this Zoom session, please put any questions. This is a webinar format, so you need to put your questions in the Q&A window. We will hold the majority of the questions till the end of the session. We might end up typing in some answers to some easy answers that we could just type into the Q&A window. We will be holding most questions till the end. And again, I'm going to introduce the speakers now, and then we'll just go straight through the presentations. Slides will be emailed to everybody in follow-up to the webinar, and this will be recorded so you can also access an audio and video, and you can feel free to share with anyone that you think might be interested. Additionally, there's a listserv that you can subscribe to receive alerts and find out about additional projects and webinars. And again, we'll have all that posted in the chat. So now on to the main event. So our two presentations, the first one will be about the evidence-based public health workforce loan repayment program as a recruitment incentive for people in state and local health departments, which we'll hear from Dr. Leider and also Nicole McDaniel. Both of them are from our University of Minnesota and our Center for Public Health Systems Leadership. Then the second presentation, you will hear from two of our principal investigators in CWORPH about the public health occupations codes for public health that compares with the existing SOC codes. And you'll hear from Dr. Janette Dill, also from the University of Minnesota, as well as Dr. Heather Krasna from Columbia University Mailman School of Public Health. So thank you, and we'll hear from our presenters, and then we'll jump back in with Q&A afterwards. Thanks so much.
All right. Nicole, are you going to share the screen?
Yes, sorry, I'm having a technical issue.
Oh, no problem. I can if you would prefer, just let me know.
Yes, if you don't mind, I'm just...
Sure. Hey, everybody. Pardon our technical difficulties real quick while we get up and running. As Beth said, my name is JP Leider. I am an associate professor in health policy and management over at the University of Minnesota. And we're going to be talking today largely about student loan debt burden. So here we go. Nicole, are you?
Yes.
Let me know when to proceed.
Yes. Appreciate it. Thank you. JP and I would like to recognize our co-contributors on this project, Hunter Doyle from the University of Minnesota, Mariah Robbins, Rachel Hare-Bork, and Brian Castrucci from the de Beaumont Foundation. Additionally, some acknowledgements. Our project was supported by CDC and HRSA awards. PH Wins is conducted by the de Beaumont Foundation and ASTHO, and opinions presented today reflect only those of the authors and do not necessarily reflect the positions of HRSA, CDC, de Beaumont, or ASTHO. So just some quick background. Governmental public health employment has seen a decline dating prior to the COVID-19 pandemic. From about 2009 to 2013, governmental public health saw a loss of approximately 40,000 jobs. Pandemic response and relief funds provided a hiring boost, but the sustainability of this growth is in flux. The public health workforce demographics are not reflective of the communities served, as evidenced through COVID-19 outcome disparities. High student debt may make service in government public health unattractive due to often lower compensation. Governmental public health is frequently less financially lucrative than private industry. And as a result, most grads opt for jobs in the private industry due to myriad cost of living considerations, including student loan debt burden. There are a variety of loan repayment options. However, few are available for the public health graduate. HRSA offers their National Health Service Corps loan repayment programs. These are primarily available to clinical health care providers working in approved health professional shortage areas. PSLF, or the Public Service Loan Forgiveness Program, is probably the one we most frequently encounter for public health workforce. Loans are forgiven after 120 on-time payments. It's about 10 years on an eligible loan. It's a full-time work requirement that is considered a 30-hour work week or 30 hours per week for qualifying employer. Barriers for government public health workers can include lower wage jobs and the resulting capacity to make consistent payments. And the PSLF's historically high denial rates and sometimes unclear employment eligibility criteria. The 2022 Public Health Workforce Loan Repayment Program statute was passed in the 2022 omnibus, but no funds were appropriated to this program. It would pay the approved applicant up to $50,000 for an eligible loan if that individual is enrolled as a student in an accredited institution of higher education or school of public health in their final semester, and that they'll be employed by or have accepted employment by a state, local, or tribal public health agency upon graduation, or if they graduated within the preceding 10-year period from an accredited institution of higher education or school of public health, and they're employed currently by a state, local, or tribal public health agency. The statute will expire at the end of this current government fiscal year without further reauthorization. Our study aims to characterize the national landscape of student loan debt for state and local public health graduates. College scorecard data can offer a snapshot of loan debt upon graduation, and there are federal survey data that show broad information about borrower age, location, debt size, et cetera, but they're imprecise in showing the population who would benefit specifically from a public health workforce loan repayment program. We also consider in the study the role of student loan repayment and forgiveness programs on workforce development, recruitment, and retention programs. The study utilizes 2024 PH Wins data. There are approximately 152,000 invited to respond, with 56,595 respondents for about a roughly 35% response rate. The student loan questions were new additions this year compared to prior iterations of PH Wins. Questions were included to understand student loan debt and its burden to the government public health workforce. Again, there is student data available on loan burden at graduation, but this tool helped obtain additional information specific to the public health workforce, those who may accrue debt from multiple institutions and those who have things like Parent Plus loans. Then finally, our survey questions in the new loan burden module ask the following things. including loans for your own and others' education, about how much have you borrowed in total. It includes loans which no longer have a balance. It asks, as of today, including loans for your own or others, about how much remains of your student loan debt, and of your current student loan balance, approximately what percentage is private, federal, direct, parent plus, etc. And PHWINS also gathers additional demographic data and workplace information, which we were able to use in our analysis.
All right, I'll take over. Thanks, Nicole. There are a couple other items related to methods and analysis that I'll discuss as we move through the results, but largely we did by very descriptive analyses and built an interval regression to look at the correlates of student loan debt. So importantly, these are still in flux. Please don't cite them. While you'll be able to look at the recording, things aren't final until the data set is final from the data owner at Beaumont. So hot off the presses. Let's start off by looking at student loan debt remaining among those who have student loan debt. So that's an important consideration. I'm just going to say up front, we'll talk about two kinds of statistics. One is kind of the overall burden of all respondents, including those that never took out a loan, paid down their loan, and then still have a balance. And then sometimes we'll only look at the burden among those who have current student loan debt. So you can see those are two slightly different takes on this same question. So what you can see here is in the Midwest and the Plains, slightly lower student loan debt burden overall compared to in the geographic Northeast. But that largely, on average, state by state, you're looking at between $40,000 and $60,000 or so of student loan debt among those with a balance. So that's sort of the high level number that we should start with. One of the things that we wanted to do was look at the differences in both disbursements, original disbursements by age, how much you took out, and then in a minute we'll look at balance and kind of balance to original disbursement. But what you can see here is that for those roughly under the age of 50, there's somewhat of a different experience in the percentage of folks who are never taking out student loans and then taking out relatively smaller amounts compared to those 50 and over, right? And we know that largely tracks from other studies we've seen in the private sector and the broader public sector. But what you can see is there's a pretty substantial amount of folks who are taking between $40,000 and $100,000 consistently across the age groups, especially among younger folks. How does that relate to student loan remaining by age? I'll show you a few different charts to really explain this story. But a top line important point is a lot of student loan debt is getting paid down as folks proceed. That is important to keep in mind. However, you can see that there's also a substantial percentage of folks that have pretty high balances working in governmental public health, where again, wages tend not to be competitive with the private market in some occupations. So maybe unsurprisingly, as folks get older, there's a smaller proportion that have any debt. But one of the things that you do see come in, of course, is the parent plus loans. And so that is something that hasn't historically really been talked about for the public health workforce, but a pretty substantial portion of the workforce does have that balance. And so that means people have student loan debt for their kids that they're still paying off into their 50s and 60s. All right, so here will be a few charts to really kind of tell this story. What we're going to show you is a slightly higher age gradation. And then the colors here are the percentage of your current balance, the respondent's current balance, compared to the original disbursements. And then we'll do that by age. And then on the next slide, for those playing at home, you'll be able to look a lot more closely at balance compared to your original disbursement level. So what are some top lines here? Well, maybe unsurprisingly, folks who are under the age of 35 or so, that roughly the majority have 75% plus balance remaining. Not super surprising, but there is this measure that is a sign of problems, which is that when your balance is more than your initial disbursement, right? So Maybe you aren't paying down everything and things are climbing in terms of your balance. And that's something that we're observing in a pretty substantial proportion of the workforce. Now, generally, that ratio is relatively, I don't want to call it modest, but we'll say close to 100% for those who are over 100%. But the fact that there are so many folks that are in that circumstance is worth commenting on. And of course, this inverts as folks get older with a little bit of a bump back from the Parent Plus loans. So apologies that this is smaller. I know some of you are going to be right up on your screens, but here's what you're seeing. So each of these panels is that same slide about balance versus disbursement. And then the panel is from the level of original disbursement. So, between $1,000 and $20,000, 20 and 40 and so on. And so you can see there is a little bit of a difference, especially for those who have more than 100,000, right? But roughly you see a pretty similar story that in kind of the early to mid-career phase, there's a pretty high balance. And it slowly comes down, but that there's still even a substantial portion of folks who have more than 100% balance. And that's been shown to be quite brief. All right, let's take a little bit more of a dive into some of the disbursements by demographics of interest. So this is race and ethnicity. So blue, again, is the zero, either you never took it out or you took out, 1 to 20 in orange, 20 to 40 in green, 40 to 100 in teal, and then over 100 in purple. You can see there are some differences by race and ethnicity. Many of these groups are big enough where even relatively close distributions are statistically significantly different. However, some groups, especially the Middle Eastern and North African staff, Native Hawaiian and Pacific Islander staff, American Indian and Alaska Native staff, relatively small number of respondents because there's a relatively smaller proportion of these staff in the workforce. So those have, I would say, a little bit of wiggle room if we're thinking about these as nationally representative estimates. But for Asian staff, Black or African American staff, Hispanic Latino staff, and white staff, those differences that you see, any distribution is going to be pretty statistically significantly different. So you can see that Black or African American staff are more likely to have taken out any loans compared to Asian or white staff. And this does, differ a bit by age, but largely. So let's get into the regression results real quick. So what I'm going to show you are the results for each demographic of interest from a larger interval regression model where we looked at the correlates of student loan debt remaining. And I'm just going to kind of show those in each panel just to kind of make it a little easier to interpret. What you can see, for instance, in the age panel is that those who are 65 plus are much less likely than those 50 to 64 to have lower student loan debt remaining compared to those who are younger, right? So that's kind of logical. But one of the things that I think is kind of interesting here is you see kind of the similar story, what you would expect to see, I suppose, for like educational attainment, those who have higher degrees, have larger student loan debt remaining, all else equal. One of the nice things about this regression model is you can kind of pick apart some items that might be hard to tell the differences otherwise, right? So if you're younger and you have higher degrees, right, you're much more likely to have a higher student loan burden than those who are older. And then again, the demographics we just saw on the last slide largely hold here. So if you are Hispanic or Latino, you are pretty close to white staff in terms of relative student loan debt, but you can see that it's much lower for Asian staff and quite a bit higher for Black or African American staff. We also note some differences by gender here. Okay, the last slide I want to show about disbursements and proportion remaining here is what kinds of loans folks have by age. So the story that you're essentially seeing is that among those with student loan debt, the vast majority are in federal direct loans of the various kinds. The private percentages is pretty consistent, but then, as we talked about before, as you see staff getting older into the range where if they have children, you might expect them to have some debt. That is really coming through, right? So among staff who are 50 plus, student loan debt associated with parental status is a pretty big contributor to total balance. But a lot of these folks also have their balance that they're paying still. So when you think about these programs as kind of proposed, as passed, as being administered, we had a question about relative burden, balance, and so on by program. Now, this is completely theoretical, right? Because one, the Public Health Workforce Loan Repayment Program was never funded, so folks aren't getting money. And that's one of the reasons we started this project, to kind of think about the contours of what a program might look like. And then PSLF has been, I would say, much improved in recent years in terms of uptake and ability to do that efficiently and on time. But with the new administration and their stated preferences around PSLF, I would expect that program to change in terms of use. So what are we seeing here? When you look at folks who are theoretically eligible for neither program, workforce loan repayment, PSLF, or both, the vast majority are federal direct loans, but also for PSLF, the plus parent loan, which you can think about including. So really you're above 65 to 70+%. So that's the majority of the balance that folks are holding. And so it's a very relevant and meaningful program if implemented for Public Health Workforce Loan Repayment Program, and is presently for PSLF. So as we wind down here and we prepare for the next presentation, want to give a couple limitations. So the Public Health Workforce Interest and Needs Survey, while enormous, right, over 56,000 respondents, some folks do opt out. And in this case, we had a couple state agencies this year and locals that chose not to participate. And that's relevant as we think about national representativeness. There are weights to kind of handle non-response, but that's important. One of the other things that I alluded to, but we can be explicit about, is that the student loan balance question are in intervals rather than point estimates based on literature around kind of respondent comfort for addressing sensitive topics. So while we can handle the interval pretty easily with statistical processes, there is some imprecision there from how the question is asked, and then also how folks are choosing to respond, right? If they're being comprehensive in their estimates. So we would expect a little bit of variability between reported and actual debt, but well within the tolerances that we're showing today. So like we talked about, we've got a balance nationally for those that have student loan debt of about 50 grand. 40% of the workforce does have a student loan balance of some kind. And it's extremely relevant, I think, that we are in times of transition. We have folks that are planning to leave or retire at pretty high rates. We have a lot of turnover since COVID and even before it. And loan repayment is historically a really important tool to get young folks into the workforce and, importantly, keep them. One of the problems that we have, what you've heard on other webinars, is that we're having trouble somewhat getting folks into the workforce, but a large trouble keeping young folks in the workforce. So I think we'll leave it there, and I'll transition to the next presentation. Thank you. Nicole, are you still having issues with your PowerPoint, or are you able to share?
I think Janette is going to share. It's
Okay, great. Thanks.
Yep. I'm just pressing all the buttons. All right. Hello, everyone. Heather and I are going to spend some time today talking about kind of obscure topic, but one that has some wide-ranging impacts. And we hope that by the end of our presentation, we will have convinced you that this is something you should also care about. So we're gonna, the title of our presentation is Where Are the Public Health Workers? Building Successful SOC Packages for the Public Health Nurse and Disease Intervention Specialists. And we're gonna start by talking a little bit about what a standard occupational code package is. That's what SOC stands for, and Heather is gonna explain.
Thanks so much, Janette. It's great to be here and looking forward to this. So SOC stands for Standard Occupational Classification. And what that means is it's a way of describing and categorizing different types of jobs, occupations. There's different ways of describing these. And it's an important federal standard maintained mainly by the U.S. Department of Labor and the Bureau of Labor Statistics. And it's used by a lot of different federal agencies to classify different kinds of workers into different occupational categories. And the data that we get from these SOC codes is very helpful because when you have a code to describe an occupation and it's distinctive, then the U.S. Department of Labor will gather data on how many people work in that occupation, how much money do they make, what kind of industries hire them. Is this a growing or a shrinking occupation? It's also used in all kinds of labor market information and career guidance information that is available to job seekers and college students who are trying to choose a major. And there's sort of, it is set up sort of like you might think of how different species of living things are categorized. You have your genus, your species, your family, your species, your subspecies, and so on. So there's kind of these broad groups of occupations, and then there are very detailed occupations. These codes are revised. They don't actually, I think, legally have to be revised, but they generally get revised about every 10 years. And we could have a whole conversation about whether that's frequent enough. As you can imagine, there's probably no SOC code for artificial intelligence engineer or whatever is the newest job that has just been invented. So these do change over time, and it's a whole process to introduce the idea that there should be a new code for a specific occupation. And it's a combination in terms of getting a new code for a new or different occupation. There's a process that includes data gathering and evaluation and information, which is research, which is what we've been doing in the last year. And there's also some amount of advocacy because there's a committee that convenes to determine who's going to have a new code. And if you are advocating for an occupation that has a professional association, or it has a specific union or a credentialing body or something, that is sort of part of what they keep in mind when determining if the occupation is significant enough and distinctive enough to get a new code. So to be very honest, I don't know where we are right now in that process of revising. There's so many things going on. I'm really not sure where we are, but we'll talk about what we did to gather data about a particular two different occupations that exist in local and state health departments that do not have a SOC code. And therefore, there's no way to really research them using federal data. Let me move on.
So it is a little unknown of what's happening now, but I'll talk through sort of the timeline for revising the standard occupational codes. And I was, Heather, as you were talking, I also think it's important to realize that they remove them too. Like they add to the occupational code, but they also take them away. So as occupations become less or become obsolete, they'll remove them. Or sometimes they also just decide to clump people together and use less specificity. So they make pretty substantial changes every 10 years. So the committee to revise the SOC codes has been pulled together. At least they had been as of a few months ago. And And so in 2024, in August 2024, they posted the first Federal Register soliciting public input. So we pulled together 2 packages that we submitted to this federal committee, along with many, many thousands upon thousands of other individuals who also advocated for SOC codes. Now the committee is working on reviewing all of the comments and packages that were submitted through the Federal Register. And then in 2027, there will be a 3rd Federal Register notice announcing the final 2028 SOC structure and including the occupational codes, the new occupational codes and titles. And then in 2028, we'll have the implementation.
So when thinking, again, I briefly touched on this, but when this committee convenes, traditionally there have been certain priorities or things that they keep in mind when determining if something deserves to have its own new SOC code. And essentially, you have to be able to show that the actual job tasks or work that a person does while they're doing their job has to be distinctive and unique. It kind of has to have its own fingerprint in some way. The way I think of it is that if I were to see a description of this occupation and I didn't know the job title, I would be able to guess from reading the description, okay, this is a community health worker and it's not a health education specialist. And there's some overlap here and there, but I can tell by just reading it or looking at the job tasks that it's one and not the other. The responsibilities and tasks have to be internally consistent. And, you know, this can be a challenge, for example, when we're talking about jobs, and we're going to talk in a second, the 2 that we chose, one of them is public health nurse. And as you may know, a public health nurse who maybe works in a smaller health department may wind up doing a whole host of different job tasks. And they may seem like they're doing the job of several other people all at once. But the description has to kind of be internally consistent enough where you can't say, you know, they do a variety of things and it could be A, B, C, D, and E. There has to be some sort of a consistent set of things that you can say all public health nurses do these 10 things. And I don't know if there was ever information on the minimum number of workers in a particular occupation to justify a new SOC code, but if it was tiny occupation, it was more likely to be rolled into some other broader group. Next slide. So in terms of how we chose these 2 occupations to focus on, to gather data to see if these make sense as a distinctive standard occupational classification code, this is based on some research from a couple of years ago using PHWINS, the Public Health Workforce Interests and Needs Survey. And it's a kind of in the weeds process, but basically what we worked on is matching the titles of the individuals who answered the PHWINS and looking at what job category they said they worked in, which is one of the questions that people answer in PHWINS. There's like 2021, I think it may have been a different number. I don't know. There's like 76 or so, if I'm remembering, in the 70s, number of different job categories. And then taking the information and using a machine learning tool to match them with SOC codes. So looking at job titles and matching to SOC codes and seeing if they matched up with what the job category was that the person said they were working in when they filled out PHWINS. And when we compared and looked at people who said when they filled out PHWINS, I am a disease intervention specialist, for example, we found that this machine learning tool did not know what to do with those people. And they were not matched with anything consistently. There was just, basically the machine learning tool came back and said, don't know, have never heard of this, have no idea what SOC code, or it was matched to a range of different codes that were not very consistent with each other, were kind of all over the place. And so several different occupations that exist in health departments did not come up with really clear matches. Now, public health nurse matched a lot with nurse because, of course, the machine learning tool that did this matching could make a good guess that this must just be a nurse. But when you look at what public health nurses do, it's distinctive and different from what registered nurses may do in many other any other settings. And so this is part of why we picked these occupations to focus on. Next slide, please. So we then, after coming up with a list of different occupations that didn't have a clear match, we then had to prioritize which of these make sense to also have a SOC code package or a list of explanations of why these make sense. And so one of the things we looked at is, again, is there not a clear match? Is it distinct from an existing code? There's other pieces in the puzzle. There's other categorization tools like the ONET Online, which also has information on different occupations that's connected to the SOC codes. And we also made a decision to prioritize occupations that are a fairly sizable percent of the workforce in public health. Next slide. And then we also kind of used a prioritization rubric to decide which to prioritize. And this is maybe a little hard to see, but you can kind of see the questioning that we used of, the other piece is, does the occupation exist uniquely or specifically in a health department? So for example, policy analyst is a job that shows up in all kinds of government agencies and also nonprofits and consulting firms. And it doesn't actually have a very clear SOC code match, but we chose not to prioritize that because, again, it's not so specific to health departments. And then we looked at which ones of these occupations make up more than about 0.5% or more of the public health workforce. Does it not have a clear existing code? And then is there a professional society that might be interested to potentially advocate for this to be a new code? Next slide. Go ahead.
When we were looking at developing the SOC code packages to submit to the Federal Register, we looked at a few prior SOC packages that were successful and were given a new SOC code by the Bureau of Labor Statistics. These included the medical registrar role and the health education specialists. In all cases, or in both cases, they were able to align their packages very closely to the revised principles that are important to the BLS. They got strong support from professional organizations. They were able to show licensing and certification requirements to show the uniqueness of the profession. And they had a consistent and clear message throughout the packages.
So in terms of how we then put together the data, sorry, I was going to start chatting. I can talk a bit about the literature review, and then if you want to talk about, I can talk a little bit about this piece as well. We did do a fairly thorough literature review and then did some coding to look for themes in terms of occupational descriptions. And of course, there was actually a lot of literature about public health nurses. It's a pretty well-established occupation for many years. There were fewer for disease intervention specialists. I don't know if you wanted to add, Janette. I didn't mean to
No.
jump in.
Okay. So we first conducted the literature review, and then we did a bit of a quantitative analysis. Heather, do you want to talk about the public health nurses, and then I'll talk about DIS?
Yes, perfect. So we did look at PH wins, and we also looked at a national survey of nurses, NSSRN, a gigantic survey of nurses. And we then looked at the job tasks that public health nurses responded to in the NSSRN study, and compared them to other nurses and to see if there was a difference using statistical methods. So just mainly looking at their job tasks according to the survey responses.
And then for both the disease intervention specialists and public health nurses, we used Lightcast job postings data basically comparing job postings for public health nurses versus nurses in clinical roles. And then for DIS, we compared them to epidemiologists and community health workers. And then we used t-tests to test for differences in the skills that were being posted in these job listings. And we will describe those analyses in the coming slides.
So for the public health nurses, we did see that there were differences in terms of looking at the job postings from this. There's this database that was mentioned called Lightcast, which scrapes the internet for millions of job postings and then categorizes them. And so we did some searches by job title and categorization and found a data set of public health nurse jobs and compared them to non-public health nurse jobs for other nurses. And, you know, we found, which makes sense, that, you know, some of the skills that public health nurse jobs ask for were more case management, and the registered nurses used certain tools and technologies that were more clinical, so like medical records in Epic instead of other systems. And then with NSSRN, we looked at people who responded to the survey and said they were either a public health nurse or school nurse versus all the other respondents. And again, we saw that the public health nurses or school nurses did more kind of the other category of tasks, whatever that includes, and then care coordinating and research, where of course the more clinical nurses did more patient care and actually more teaching or precepting and management and supervision. And then we did a bit of an analysis looking at people who responded to PHWINs, keeping in mind a big caveat, which is that everybody who responds already works in a health department. So we were looking at nurses who work in health departments but responded that they are clinical nurses, as opposed to people who work in a health department and said that they were a public health nurse. And so looking at what they actually did, the public health nurses were more likely to focus on communicable disease or maternal child health, which makes plenty of sense. That's what they tend to focus on. Public health nurses were more likely to be working in local versus state government, according to what we saw. And then the public health nurses were more likely to be certified in public health, the CPH. And then looking at Lightcast, this is again, the data set is able to pull out various types of skills or competencies. And you can see there's plenty of overlap between the regular registered nurse and a public health nurse. There is a little bit of difference in terms of multilingual or language skills and investigation, doing presentations, which is not so much the case with some of the registered nurse, but some of the other kinds of skills or competencies are a little more illustrative of differences. So next slide. So with technology, you can see if you look at the registered nurse that they have a ton of different, very specific, you know, medication management, medical software, payroll systems, things like that. Medication dispensing software. Everybody uses Microsoft Office, but then the public health nurses were using a few other slightly different tools. Next slide. To me, this is where I think the most interesting difference shows up, where you'll see that the registered nurses, of course, had more time working in an ICU, doing acute care, pediatrics, emergency departments, very specific clinical types of operating room procedures and so forth, where public health nurses, of course, did a lot more in, of course, public health, communicable disease, health education, community health nursing, infectious disease, vaccinations, and of course, you know, other things such as tuberculosis management that are very much more focused on public health.
All right, now I'll talk briefly about the disease intervention specialist role. So the CDC, I feel like most people are familiar with the public health nurse. The DIS is a little bit less well-known. People have a little bit less understanding about what that role involves. The CDC defines DIS as a public health professional who use contact tracing and case investigation to prevent and control infectious diseases. While DIS started in the field of STIs and HIV, their investigative skills have expanded to other diseases. Obviously, contact tracers were used widely during COVID, less so now. In the job postings data, we found that the top specialized skills for DIS were communicable diseases, not surprisingly, infectious diseases, disease control, and disease prevention. And all of these skills were significantly higher in job postings for DIS as compared to job postings for community health workers and epidemiologists based on t-tests. The reason we compared in our analysis DIS to community health workers and epidemiologists is because, as Heather talked about in her past research, these workers, they don't have an occupational category, and so they are often put into either the epidemiology or the community health worker categories. But our analysis tries to demonstrate that they have very different skills than both of these occupations. I also have a Venn diagram. One of the graduate research assistants working with Heather at Columbia put together these Venn diagrams for us, and we love them. But here you can see that DIS, EPI, and CHWs are all included here. They do have a lot of overlap in the middle there around communication, computer literacy, coordinating, etc. However, you can see that DIS has their own unique skills, and these include a focus on analytical thinking, cooperation, information gathering, record keeping, tactfulness, and teaching. And then when we look at the specialized skills, we see that the DIS role focuses heavily on sexually transmitted diseases, phlebotomy, risk reduction, infection, contact tracing, etc. So, we think that the Lightcast data really demonstrate that the DIS role is quite unique from epidemiologists and CHWs. All right, so to wrap up, what is, sort of a complicated group of analyses, we argue that DIS and public health nurses are unique occupations that perform specialized skills within the labor market, that they are unique roles that are not filled by other occupations, and that these occupations will be strengthened by having their own unique SOC codes. The results of the SOC package submissions, which we have put in 2024, are to be decided in 2028. So we have a ways to wait, and it's a bit of a black box until then. We have a manuscript on the disease intervention specialist that is forthcoming, and we encourage you to seek that out. And then the public health nurse manuscript is under review and hopefully will be forthcoming soon too. Now we're happy to take questions about any of the topics discussed today.
I wanted to add one little thing about these packages is that we did also submit them as a public comment during that public comment window. And we were both of our packages went in with a lot of letters of support from various public health organizations. I was very pleased with the amazing turnout of the public health nurse associations and organizations and individuals and groups that submitted letters of support for that package. So who knows what will happen, but it was a very, I think, solid effort of both research and advocacy. So.
Great. So thank you guys for those really helpful and very in-depth presentations to explain these complicated issues and clarify them for us. So I noticed that there isn't any questions in the Q&A. So audience, I have a number of questions, but I would love to hear from you all if you have some. So please go ahead and put them in. I'm going to start with our student loan project that we heard about first. From Dr. Leider and Nicole McDaniel. So I have a few questions for you all, and then next I'll have some questions on the SOC codes. So first off, on the federal loans, I guess, and thank you for those helpful graphs that really kind of laid this out in a more specific way. I think I'm going to start off with the bottom line question, right? So we know we've had so much trouble with recruitment and retention in the public health workforce. Do you think, obviously we know now this public health loan forgiveness is going to expire this year, But do you think that this is key to our recruitment retention problem, or would you put your energies into other things right now with all of the challenges that are going on?
Yeah. Uh, I I think it is a really hard answer, and I imagine, Heather, you might have some strong opinions on this too. It's pretty clear that the policy environment is not super conducive to anything related to student loan forgiveness or repayment, right? The new administration has been very upfront about their priorities in this area, and we haven't seen a lot of movement in the House or the Senate to try and move these things forward. Now, there is some talk about dramatically changing how the PSLF works. And so there might be some, activation around that issue that could spread out to other related topics. I don't think that student loan forgiveness or repayment is a cure-all for our problems in recruitment and retention, but I think it's a really important component. Because while we have a public health workforce that substantial portions are eligible for PSLF, that's really like long term recruitment and retention. I'm sorry, long-term retention, not recruitment. And the particular problem we have right now, Beth, is that we just are really not able to keep people who are under the age of 35 for more than a couple of years. That's kind of normal, right? That age group has been shown to jump around job to job, sector to sector. But they are also exactly the people that are replacing folks that are retiring, coming in more highly trained than in previous generations, have higher expectations around earnings and non-traditional benefits and things that we could all talk your ear off about. And compensation packages are part of that, but it's not the only thing, right? So I think it's part of a holistic approach that we need to engage in, but a hard one right now to think about.
A multi-prong approach, and it sounds like you're saying more for retention than recruitment right out front. So
yeah, I mean, I think both are interesting and important, and I know that evidence shows that people right out of school look for whether repayment is part of it when they're considering jobs. So I don't want to downplay it for recruitment, but yeah, I mean, you got to keep people once they show up.
So one more quick question, because I know we're running out of time, and I definitely want to ask about the SOC codes as well. It was great that you showed the breakdown, and I honestly have to say I haven't seen things like this. Where you showed by race and age and all of those different things. So the question I'm going to ask you, and it actually relates to the question that just came in too about scholarships and financial need, was that part of it? And my question is, as people age with the intergenerational wealth gaps that we're hearing more and more about, do we see a wider divergence? Because obviously people from families with more resources might have their financial burdens reduced by inheritance or other forms of wealth, whereas people in lower income families might actually have their financial burdens increased, where if they have to help pay for somebody's care. So I guess I was just trying to see long-term how you see that divergence. And again, the question that someone else was asking at the upfront about scholarships or financial need-based things, how that also might play a role.
Which is a really excellent question. So this is a multifaceted answer. I think the short answer to your first question is that there's excellent evidence across all sectors about the differences in student loan debt that people experience based on parental wealth, right? To your intergenerational wealth question, and parental ability to pay. It's factored directly into the student loan options that you're given, and some of them are deferred, some of them are just somewhat equivalent to grants, right? And for those folks, that would decrease their debt depending on where they choose to go. But to me, one of the key measures is what proportion of any given demographic never took out any loans, and then still has loans that are in the 75 to 100% thing, because both of those, one has to do with what are you kind of getting up front, whether from your family or from grants or scholarships, and then the second is your ability to pay based on what you're earning. And so also looking at at these burdens by salary, I think it really tells that story.
Yeah, great points. Okay, let's turn to the SOC codes. And I guess the first question, As just a regular person, trying to understand why these SOC codes are important, and I guess I'm going to flip that question a little bit. So you mentioned about nurses and disease infection specialists. What would happen? Can you translate this into just basic why it would benefit the field if we were to get those SOC codes like the way you were discussing? So could you give us a why it would matter, how it would help?
I can quickly say that the right now, to be able to answer a question like how many public health nurses are there who work in local health departments, for example, you can't really use data from the federal government to answer questions like that, because the sort of granularity of the data that's available in the Bureau of Labor Statistics information, it will show you how many nurses work in local or state government, but not how many work in health departments within the government. And, a state government can have many places a nurse could work. And so, there's not a really good way to count that up. So just being able to use the federal data to even do enumeration would make a big difference. And then also being able to compare salaries more accurately would also be useful. And then the third way that it's important is that when an occupation doesn't have one of these codes, that makes it that much harder to make people aware that these jobs exist. And so, that means there's sort of you kind of have to, it's an uphill battle to explain to, let's say, a nursing student that, hey, there's a job that you could do in your local health department. Have you thought about that? Because there's not descriptions of that available in the places where people are doing career assessments and things like that. So those are just some reasons. I don't know if you want to add any more to that, Janette.
Yeah, I mean, I would say probably the biggest reason is to have a presence in federal data, and to be able to enumerate the workforce in federal data sets. And there are very few public health occupations that you can do that with in the federal data sets that are used for all different sorts of reasons. But it would be the healthcare occupations have strong enumeration and articulation in the federal data, and it would be great to have more of a presence of the public health workforce.
Great. Well, I think we are running out of time. I just want to thank our presenters. And I think given the context of this changing federal environment and many of the work that we're doing is questioned. So having the ability to have this documented and find out how many people actually are doing this work and why we need them. So I think these are all super important. And thinking about the loan repayments as one option of how we might be able to better support those people that are coming in to work in health departments and help retain them, I think are all critical questions right now. So again, I want to thank all of you, and I want to thank the CWORPH Consortium for exploring these topics that might often be forgotten in these days of all the headlines, but are ultimately really, really critical to the public health infrastructure. So thanks everybody, and thanks for all of you that joined us, and for any of you that are doing this public health work day in and day out. Thank you. We appreciate your efforts and your public service. So thanks so much, and everybody have a great day.